Hi folks, this is Dr. Rob Cywes and my good friend and compatriot in this space, Dr. Ken Berry, who all of you should watch. I mean, he is absolutely brilliant. Ken recently did a video a week or two ago, and I'd urge you to go and watch that first. And the video is specifically, stop taking baby aspirin. And Ken is someone I trust. He's someone who's a mentor and a colleague, and I really like his work. But what Ken did with this video is he looked at a new set of guidelines from that were published in I believe, the American Medical Association journal, and really come from the American Cardiology space, where they have changed the guidelines for baby aspirin. And the recommendations for baby aspirin are guidelines based on epidemiologic outcomes. And I want to caution and throw out really big red flags to some of these guidelines. And Ken based his entire talk appropriately. I agree completely with what Ken had to say about generically taking medication. But the whole purpose of what we do in our space is to individualize therapy. And I think to throw out a blanket statement whether you should or should not take a baby aspirin is so wrong. And so in support of what Ken did, but as an adjunct to what he talked about, I'm looking to give us a more detailed, specific reason to take or not to take an aspirin. Because there's huge value to anticoagulation therapy, which is what aspirin is a representative of, versus clotting disorder. So when we look at the new guidelines, I'm going to throw them out. I'm just going to carte blanche throw out the bullshit guidelines. Because guidelines are generic and I want to treat you as an individual. So here's my thinking. And if you want knowledge about this, give us a shout, 561-517-0642. You can set up a visit and we can uniquely look at you. So one of the biggest issues, the battlegrounds with these guidelines, is the difference between physiology, how does something work and what does it do, and epidemiology, what are the outcome studies? And they get a whole cohort of people that are very dissimilar, and they study them and say whether something's good or bad, instead of understanding the physiology. So let's first and foremost start with the physiology of aspirin. What is aspirin? Aspirin is a medication that in the human body does a couple of functions. Number one, it is a global anti-inflammatory, a non-steroidal anti-inflammatory drug. It plays a role in inflammation and decreases inflammation. So if you have a very pro-inflammatory environment in your body, aspirin benefits. It can benefit from a headache, it can benefit from joint pain, hangovers, excessive muscle use. Aspirin has a global anti-inflammatory response. Secondly, and specifically, aspirin is a molecule that blocks something called thromboxane A2. What's thromboxane A2? Thromboxane A2 is a molecule that triggers platelet activation. And once platelets get activated, they promote the clotting cascade, and they promote the cellular inflammatory clotting cascade in the blood vessels. So platelets, when activated, can cause blood clots. And you can either get acute blood clots in your venous system, or you can get clotting in your arterial system when the endothelium is activated, and you can get plaque disease happening. So aspirin blocks platelet activation, which is the conversion from a thrombin or fibrin clot to a cellular clot. And it has value in reducing blood clots in the legs as well as plaque formation in the big vessels. And that's the physiology. And in my laboratory time in my Ph.D., I used aspirin as a drug to modify the clotting cascade. So let's go through the numbers. Number one, in otherwise healthy patients below the age of 35, I would agree that aspirin is not warranted. Now, who under the age of 35 might take an aspirin? If you have lupus, if you have documented autoimmune disease, rheumatoid arthritis, juvenile arthritis, an aspirin would be indicated by me. Now, let's stop there for a second, okay? What is the reason not to take an aspirin? Aspirin, by definition, increases bleeding time. So if you cut yourself or if you have a popped blood vessel somewhere, anywhere, either by cutting yourself through trauma or internally. Aspirin prolongs the time through which you bleed, called the bleeding time, and reduces or increases the length of time to form a clot to plug up the bleed. So if you cut yourself, you bleed a little bit longer. If you bump yourself, you bruise a little bit more. If you get a bleed in your gut, you'll bleed a little bit more. If you have ulcers, you'll bleed a little bit more from them. If you have bleed in your joint or your brain, you'll bleed a little bit more. But it's the lowest of all the anticoagulants. So when we go up, the big time anticoagulants that interfere with the clotting cascade, the Plavixes, the Eliquises, those are the big time anticoagulants. The Coumadin was the precursor for that. They significantly prolong bleeding. Platelet aggravation blockade, thromboxane A2 inhibition by aspirin is the lowest level anticoagulation that you can have. But absolutely, if you've got a significant bleeding disorder, if you have hemophilia, if you're on other medications, or some cardiologists will use Plavix with aspirin, if you have bleeding gastric ulcers, if you have varices, if you have tendencies to bleed, of course, aspirin is contraindicated because you don't want to bleed to death. At the same time, aspirin therapy is probably the single best way to reduce the risk of blood clots and reduce heart attack or stroke risk, other than changing your diet. So as a medication, it is the first line therapy. So yes, Ken is quite correct. If you've got a bleeding disorder, stay away from aspirin. And have a physician like myself who understands that be able to work with you. One of the things we do is we look at iron indices. And if your iron is low, if you have heavy periods as a female, if you have H. pylori as a bacteria in your stomach, if you have ulcers, if you've got a very stressed out response where you've got ulcers, you've got gastritis, you've got bleeding polyps from your colon, you've had other health issues related to bleeding, yes, of course, aspirin is contraindicated. But first and foremost, under the age of 35, with clotting autoimmune disease, rheumatoid factor, positive ANA, positive lupus, significantly positive, not just mildly positive, aspirin is beneficial because of the risk of clots and because of the risk of plaque formation. Secondly, between the age of 40 and 55, 40 and 60, aspirin is not indicated for plaque disease if you have a CAC score below 100. If you're between 100 and 400 and the plaque is significant over one area, then it may or may not be indicated. If your CAC score is above 400, I would strongly recommend a workup as well as a baby aspirin, 81 milligram aspirin, once a day or maybe 3 times a week. Because even if you're pure carnivore, your risk of existing plaque rupture is high. And if the plaque ruptures, but it doesn't form a big clot, you're a little bit safer than if you get an acceleration of a clot. So in people with plaque disease, 40 to 55, it depends on your CAC score. If your coronary artery calcium score, and I would urge everybody in that age group to at least get a baseline coronary artery calcium score. It should be as common as blood work, blood pressure, and maybe an EKG. It's part of the testing. I've got another video on this. But if your CAC score is above 400, I would definitely, and there's no contraindication, I would definitely recommend a baby aspirin together with a lifestyle change. Inflammatory, quit smoking, get rid of the carbohydrates. If you're below that, I would 100 to 400, I'd evaluate the plaque disorder and then maybe decide whether or not you can benefit from a baby aspirin. If you have autoimmune disease, if you have type 2 diabetes, if you have hypertension or you use any nicotine products, including vaping, to my mind, until you stop those, until you get rid of them, that is an absolute indication for a baby aspirin a day or maybe 3 times a week until you've resolved those diseases. If you've gone 6 months without nicotine, it might be okay to come off depending on what your CAC score is, or maybe a carotid study. If you have type 2 diabetes, until your A1C is below 5.5, I would be taking that baby aspirin. If you've got autoimmune disease, you may want to consider that for life. If you've got hypertension, it is a very important drug to take because hypertension and diabetes lead to the coronary artery, an increase in coronary artery calcium score. If you've had an ischemic stroke, ischemic, which is the commonest source of stroke, a clot disorder, baby aspirin is indicated. If you had a hemolytic stroke, a bleed, no, stay away from it under those conditions. So you've got to mitigate against the risk of bleeding, but the baby aspirin a day or baby aspirin 3 times a week, very, very valuable. Now, even if your risk is low, but especially if your risk is high, for me as someone in that 50 plus year age group, if I travel for more than 4 hours, if I'm driving for more than 4 hours, if I'm flying, the day before, the day of, and the next day, I will take a baby aspirin. Why? Because this is not just about plaque disease, but blood clots can form in the veins of your leg, especially when you're sedentary, especially when you travel, and you may be a little bit dehydrated. If you go to altitude, I take my baby aspirin. I've got a low risk of bleeding, and I do not want to clot, even though I'm metabolically very healthy and my CAC score is 0. I will still take that to reduce the risk of intravascular clotting, to reduce the risk of a DVT. How often do you not hear about people? And by the way, if I get COVID, if I get an infection, if I get sick, I'm also taking a baby aspirin, because they are all promoters of inflammation and vascular inflammation. And I do not want to die or have pulmonary consequences from a DVT, from a pulmonary embolus, even though I eat right. So those are my indications for a baby aspirin. If you're older than 60, the indication is never take a baby aspirin over the age of 60. Those are the guidelines. That's bullshit. Because the assumption of those guidelines is you're going to die in your mid-70s. So here's what you do. If you're 60 and above, subtract your age from how old you think you're going to be when you die. And let's use 100. That means you're going to live for another 40 years. But if you have that heart attack, that stroke, that DVT, you may suddenly shorten that. So I disagree with 60 being some magical number at which you shouldn't take a baby aspirin. It depends on how long you're going to live for. Depends on your CAC score. Depends on your risk. There is no age at which a baby aspirin is contraindicated, depending on your health and depending on your pre-existing health, your current health, and how long you're going to live for. So it's got to be individualized. There's no guideline, no algorithm. But that's what we've become. We've become a profession in healthcare of practicing by the algorithm. And you plug into our algorithm. Doesn't matter who the hell you are. You are a cardboard cutout that plugs into our algorithm. And that's where Ken and I are on a different page. Now, I know he does this tongue-in-cheek because I talked to him a little bit about it. But for primary prevention, if you've got an increased CAC score, if you're traveling, take that aspirin. Don't take it if you've got a CAC score of 0 and you're not traveling, but then be physically active. If you've had a stroke, ischemic stroke, if you've had a heart attack, if you've got stents, if you've got your chest cracked open and had a coronary artery bypass graft, and you're not on any other anticoagulation, definitely take the aspirin if there's no bleeding risk. If you're on other anticoagulation, you're already taking something more powerful than an aspirin. But decide how old you want to be when you die. And that should come into the equation as well. Why do these guidelines also exist? Because the heavy focus by these cardiologists is on an awful drug called statins. And they will tell you all day long, if you're taking a statin, you don't need an aspirin. And I'll tell you all day long, you don't need an aspirin if you take an aspirin as indicated. I'd much rather you be on an aspirin as an anti-inflammatory drug than a statin. And I'd much rather you reduce your level of inflammation and use an aspirin from time to time as indicated, rather than live a pro-inflammatory lifestyle, because then nothing's going to help you. But in a world where we are antagonistic against statins, as I am, because of their side effects and their lack of benefit, an aspirin is a far better drug than a statin. So if you go to these same guidelines, and if they say the same group of people that do not need an aspirin should not be taking a statin, then maybe I'll change my mind. But the bullshit is this, that they tell you, you must take a statin, therefore you don't need an aspirin. And that is a categorical lie and a misrepresentation of healthy physiology. So definitely Ken is correct when he says, go and talk to your doctor about this. But don't talk to a statin-pushing doctor about this. Talk to a metabolic health specialist such as myself, and there's several of us across the country, and let us evaluate your individual risk and give you individual advice. Now remember, folks, I'm never going to tell you what you must do. I'm going to give you my opinion about what I believe to be in your best interest. And it's not going to be one recommendation, it's going to be a series of recommendations. Improve your metabolic health, lower your inflammatory risk, be physically active, eat correctly, and then let's use medication as need be. But that's individualized. That's individualized. To follow guidelines as an individual, problematic for me. I've had carnivores. I've been carnivore for 2 years and they're healthy. They have a heart attack or they rupture a plaque. Why? Because the plaque was there. And perhaps if they were taking a baby aspirin, they might not have died, or they might not have had the severity of illness. Because you can't measure something that didn't happen. The absence of a heart attack, not really measurable. And all these studies are done based on the presence of heart attacks and the presence of strokes, which is a tiny, tiny fraction of what actually happens. So we don't know what percentage don't have this as a problem. Because all the studies involve all different types of people: diabetics, obesity, healthy, so-called healthy. Individualize your therapy. Talk to your doctor, but make sure it's a metabolic specialist. This is a response to a great video done by Ken Berry, but I want to put it in perspective. I am the Carb Addiction Doc. Please leave comments down below. Please leave comments down below. But remember, guidelines are there as a cardboard cutout algorithm. The guidelines are, if your LDL and your cholesterol are high, you should be on a statin. Well, maybe not so much. I am the Carb Addiction Doc. Set up a visit, 561-517-0642. We can look at you as an individual and give you recommendations. But remember, no matter what my recommendations are, I'm never going to force you to do something. I'm going to give you information and you can decide whether you want to follow that information or not. Because we're all going to die. How we get there is our choice. Till next time.